Good morning. Today we'll be talking about non-odontogenic cysts of head and neck region. So we'll be talking about the definition of cyst first. According to pathological type, fluid, semi-fluid or gaseous contact, and which is not treated by the condition of most of the cysts, but not all lined by epithelium. Now, you can refer a book called can be of the jaws. Firstly, it can be classified as epithelial line cyst and non-epithelial line cyst. Under epithelial line cyst, it can be classified as developmental and inflammatory. In developmental, we have odontogenic and non-odontogenic. Odontogenic, we have gingival cyst of infant, odontogenic keratocyst, DC, metagenesis, eruption, gingival cyst of adults, developmental lateral periodontal cyst, botryoid odontogenic cyst, glandular odontogenic cyst, and calcifying odontogenic cyst. And non-odontogenic cyst, we have mid-palatine rafus cyst of infants, palatine duct cyst, and labial cyst. And among the inflammatory cysts, we have radicular cyst, that is apical or lateral, residual, parodontal, and juvenile parodontal cyst, inflammatory collateral cysts. In non-epithelial line cysts, we have solitary bone cyst, SBC, and ABC, aneurysmal bone cyst. And the second category is cyst associated with the maxillary antrum or the sinus, that is retention cyst, pseudocyst, and postoperative maxillary cysts. Apart from this, there are certain other cysts of the mouth, face, and neck, especially of the soft tissues. They are dermoid, epidermoid, lymphoepithelial, thyroglossal, anterior median lingual cyst, oral cyst with gastric or intestinal epithelium, cystic hygroma, nasopharyngeal cyst, thymic cyst, and cyst of salivary glands, consisting of the mucous extravasation cyst, mucous retention cyst, granular polycystic disease of the parotid. Now, pathogenesis of cyst basically consists of three main phases: the initiation, the formation, and the enlargement of the cyst. Initiation of the cyst occurs due to the proliferation of the cells, which mainly occurs due to the genetic loss of immunological surveillance and inflammatory mediators. There is increase in the oxygen tension within the lumen of this within the cells and increase of the carbon dioxide tension. Now, the formation, second phase, occurs due to the cystic degeneration that occurs within the cells, central cells, that occurs due to lack of vascularity. And this causes increase in the intercellular fluid and increase in the acid phosphatase activity. This acid phosphatase and intercellular activity fluid, they gets accompanied within the cystic lumens and they form small microcysts. These microcysts then together coalesce together to form a larger one single cyst. The third phase is a cystic enlargement. Now, this enlargement, they can be categorized into main groups: the mural growth, the hydrostatic enlargement, and the bone resorbing factors. The mural growth, they occurs due to the peripheral cell division and accumulation of cellular contents. The hydrostatic enlargement, they occur due to the secretion, transudation, exudation, and dialysis. And there are certain bone resorbing factors that also helps in the cystic enlargement process. We'll talk about mural growth first. Mural growth that occurs due to the peripheral cell enlargement is attributed to the active cell division of the lining epithelium in response to irritant stimulus. Now, Kramer suggested in 1974, they suggested that cyst enlarged by the increasing accumulation of the mural sequences. And this represents local areas of increased cell division, and they produce finger-like projections of the surrounding epithelium, and this helps in the casting off of the lining epithelium. A hydrostatic enlargement, they occurs due to the growth that is attributed to the distension of the cystic wall. This occurs due to the accumulation of certain mucous goblet cells or due to the transudation and exudation of fluid, causes excess accumulation of fluid within the lumen. Now, this can occur due to the capsular capillaries. The exudation and transudation that occur by the capsular capillaries or due to hemorrhage. Coming on to dialysis part. Now, the mean osmolality of the cystic fluid is approximately 10 milliosmol higher than the serum. That can be attributed due to the accumulation of low molecular weight proteins Now, the products that mainly degenerate the cells is shed from the lining epithelium. And this whole process is maintained by the inadequate lymphatic access to the cystic lumen. Consequently, there is net entry of the fluid from the capsule capillaries into the cystic lumen. However, presence of certain high molecular weight proteins and alpha 2 globulins, they causes increase in the permeability, which further increase in the entry of fluids within the cystic lumen. Now, there are certain bone resorbing factors, especially the prostaglandins E2 and E3. Now, these prostaglandins, along with certain MMPs specifically 1, 2, and 3, they help in the bone resorption, and they help in the enlargement factors of the cystic lumen. Now, mechanism of prostaglandin production, they occur due to the because the capsule is under influence of epithelial proliferation and certain lysosomal phospholipases from fibroblasts. The polymorphonuclear leukocytes, they break down to form phospholipid cell membranes and form arachidonic acid, which is converted by certain enzymes, prostaglandins in the taste to prostaglandins. Now, this is the whole picture of the pathogenesis of cyst, where we have the epithelial cells, proliferation occurs, cystic degeneration occurs, and a lumen is formed, and this enlargement undergoes further. Now, we'll mainly talk about the non-odontogenic cysts. Classification can be categorized as nasopalatine, nasolabial, mid-palatine raphe cyst, solitary bone cyst, aneurysmal bone cyst, and cyst of the maxillary antrum. These are all the cysts that we'll cover in this section. Cyst of maxillary antrum, we'll cover mucocele, retention cyst, pseudocyst, postoperative maxillary cyst. And the soft tissue cyst, we'll have dermoid, epidermoid, lymphopithelial, thyroglossal duct cyst, and cystic hygroma. Apart from that, we'll cover the cyst of the salivary glands, especially the mucous extravasation, mucous retention, granular, polycystic disease of the parotid. Okay. So, okay, first we'll talk about nasopalatine cyst or the incisive canal cyst. It was first described by Mayer in 1914. It is an epithelial line, non-odontogenic cyst, which is basically derived from the embryonic epithelial residues in nasopalatine canal. Now, it occurs from the epithelium that is included within the line of fusion of the embryonic facial processes of the incisive canal, which is especially between the grooves between the process that is smoothed out by the proliferation of the underlying mesenchymal growth centers. These growth centers, they refer to as the merging and nasopalatine duct cyst is formed. They occur within the nasopalatine canal. Is the opening of this canal as the cyst of the palatine papillae. The nasopalatine duct cyst is preferred to be called as the incisive canal cyst also. Pathogenesis, we have already spoken, it arises from the nasopalatine duct in the incisive canal, especially in humans. It is a vestigial remnants of this, is the primitive organ of smell. They are found in epithelial lined ducts, epithelial cords, rests, and combination of these, any of these forms. Now, these epithelial rests, they show degeneration, especially the vomeronasal organ of the Jacobson, that is a vestigial organ of smell, is thought to be the main source of these cysts. As far as the etiology is concerned, especially trauma, any bacterial infection, and any stimulation to nasopalatine duct remnants, facts that the mucous glands develop in association with the nasopalatine ducts also sometimes can cause the cystic wall. There is secretion of the mucin from the glands into the ducts when the duct is blocked. Clinical features, mainly it occurs in between the incisive canal, in between the incisors, 3rd to 7th decade of age, and gender, it is more high in the males. Clinical presentation, it is swelling in the anterior region of the midline of the palate and the labial aspect of the alveolar ridge, and there is bulging of the floor of the nose. Usually, it's usually ovoid or round in shape, and midline swelling occurs in the palate mostly. May very few cases they will associate with pain in the when you press the nasopalatine nerves. Sometimes discharge may occur, sometimes it may not. Few cases can complain only pain. Discharge is present. Usually it's mucoid and salty in taste, or can be purulent and foul taste. Symptoms are not severe and they can be diagnosed and during common radiological examination. Radiological features, the main feature for this radiological appearance is oval or heart-shaped radiolucency. That is the characteristic feature. Histopathologically, the stratified squamous epithelium or pseudostratified squamous epithelium may be in cuboidal or columnar shape, and there is a flat epithelium individual in the combination also. Most frequently, it is stratified squamous. However, there can be pseudostratified. There are presence of goblet cells in between, and which is present mostly on the surface. Rarely, cuboidal epithelium is seen. Valuable diagnostic feature is immense number of nerves and bundle fibers, blood vessels in fibrous capsule, and small islands of hyaline cartilage as seen as in the cystic walls. Differential diagnosis mainly is radicular cyst, and treatment is enucleation. Recurrence is very rare. Second cyst is nasolabial cyst. This occurs outside the bone in the nasolabial folds below the alani side. Now, as alveolus is not involved, its preferred nasolabial cyst is preferred term. It is developmental in origin and it is a soft tissue counterpart of globulomaxillary cyst. It arises from the globular processes, lateral nasal process, and the fusion of the maxillary processes. Now, this is the main, formation, how it occurs. The margins of the lateral nasal process and maxillary process bulges and coalesces together to form ectoderm that along boundary between them gives rise to a solid cellular rod. This first develops as a linear surface elevation, and the nasolacrimal ridge sinks into the mesenchyme and detaches from the overlying ectoderm. Now, this causes caudal and proliferation to connect with the caudal part of the lateral nasal wall, while its cranial extremity later connects with the developing conjunctival sac. The solid rod becomes decanalized from the nasolacrimal duct. Location of such ducts can be of the embryonic nasolacrimal rod or the duct. Mature nasolacrimal duct lined by pseudostratus columnar epithelium cells. Age is 12 to 57 years of age, post-operative especially, more common in the females. Presentation is swelling is seen, especially over here in the below the alani. Pain and difficulty in breathing occurs, and pain occurs only especially if the cystic infected. Radiological diagnosis is important. Over here, there is a lift in the alani and distortion of the nostril that usually causes diagnosis of the cyst. Intraorally bulge in the sulcus is present and the cyst is fluctuant when you palpate. Radiological features, localized radiolucency is seen in process above the apex of the incisor teeth, results in depression of the labial surface of the maxilla and detectable in tangential view. Depression of the extent, the lateral margin or anterior bony aperture of the nose, and resorption of lower part of the nasal notch. See over here, you'll get the cyst. Okay, standard occlusal radiograph is taken. Histopathologically, we have ciliated pseudostratified epithelium, and goblet cells are very, they can vary in number. The fibrous cysts are relatively acellular, and loosely or dense collagenous tissue is present with presence of mucous glands. Periapical granuloma and periapical cysts can be the differential diagnostic factors.